Thank you so much for having me come. It's a pretty exciting time. I'm going to present to you. So my name is Antu. Given name is Antu. Family name is Bui. I am the project director right now for the 98 Crisis Care Continuum at the California Health and Human Services Agency. I've been there for about a year. I'm a community psychiatrist by training. I joined the state about 3 years ago, almost now, because I was pretty excited about what's been happening in the state as far as behavioral health transformation efforts go. I was at the Department of Healthcare Services in the Medical Behavioral Health Policy Division for a couple of years, and then I've been working on this 98 project ever since, pretty much over the past year since I've been at agency. I'm so happy to tell you all about it. I have a lot of slides, some of which I'm going to go through fairly quickly. A lot of it is for reference, and then I just want to be able to tell you quite a bit more about the draft implementation plan, which is going to be released fairly shortly on November 4th to invite public comment so that we can finalize it and submit it to the state legislature before the end of the year. So I want to go over some background to this plan's development, the process, overview, give you a sense of how we organized it, talked really about how we're trying to build the services in the crisis care continuum in trying to adjust the gaps and align our efforts with all the initiatives that have been happening in the state regarding behavioral health transformation. And I'm hoping to have some time at the end for questions and answers if needed. So just in terms of background, I want to let you know about the fact that the building out a crisis care continuum is really one of the many priorities for our agency. So always keeping in mind that we're doing it as part of a larger effort and not by itself. And given that we are building upon the work that was done for a couple years already with a lot of effort from the community, many people on this board, I'm sure, had contributed to the Crisis Care Continuum Plan, which was published back in May of last year, which really provided the California vision for how we would provide essential crisis services for all individuals in California. So I highly this is a really kind of the baseline, the foundation for the work that we built upon this past year. So what the crisis care continuum laid out is, we've heard about the model when we talk about 988 nationwide, is a crisis response system where there is someone to call. If I was in crisis, I can call someone and get timely, immediate care. That if I needed to, someone could come to me where I am at in the community to respond and help me through the crisis. And if I needed to go someplace that, find a place safe to be, that would be helpful me to get to a place where my crisis could get stabilized and then get connected to ongoing care as I need it. So that's the vision that was laid out by our federal government in terms of building out 988. In California, as laid out by the Crisis Care Continuum Plan, we would like to really think about preventing crisis as at the forefront. So postvention, looping back people as well, if they're already in crisis and if they're connecting to our system through a crisis, the idea is that we would want to prevent that next crisis from happening again by using crisis as an opportunity for people to get connected to ongoing care as needed. So want to uplift that point for California. I just want to give you some context upon what we're trying to build. So we're building on top of a legacy system. When 988 went live nationwide in July of 2022, the 988 number connects to a nationwide network of the National Suicide Prevention Lifeline. There's over 200 of those centers across the nation. In California specifically, we have 12 9/8 crisis centers. And over the past 2 years, the state has built up and supported their staffing as well as trying to support them in many other ways. So now they have over 1,100 staff. And California actually answers the highest 9/8 call volume in the country. About 1 out of 10 9/8 calls in the country originates from California. And so they've done a tremendous job, our 12 centers, of answering over 380,000 contacts during the first year, and then really over 420,000 contacts in the second year of implementation. There's still quite a bit of work to do, but that's just kind of where we're at right now with the service. I just want to also highlight that California is building its own 9/8 contact handling system so that there is full interoperability between 911 and 9/8 as required by our legislation, AB 9/8. And so I want to highlight the fact that for 911 system, just for comparison to the 9/8 system, there are 450 public safety answering points in the state, and they receive about 27 million calls, 911 calls per year. This is important for us to think about because there's a lot of talk right now about 911 diversion. So if we could divert behavioral health related calls that went to 911 to 9/8, what would that look like? And in fact, if we just use a kind of a 5% of 911 calls are behavioral health related, that is actually a lot of calls that we're thinking about diverting. So if we were doing that on a statewide basis, that's something we would want to do quite thoughtfully so that we don't overwhelm the nascent system that we're building over 9/8, but we also want to do it so that there is really good collaboration from everyone involved. And then in terms of the response piece, the state has been building out mobile crisis response teams across the state through a series of grants, and we can talk about that a little bit more. But right now we have about 400 teams that we know of in the state that we have supported. There's a lot more different kinds of teams out there, but just so in terms of baseline, that's where we're at right now with our nascent system. All right, so I just want to go through AB 9/8 and what is the implementation plan development looks like. As many of you know, AB 9/8 was enacted in September of 2022, and it created the fund surcharge, the 9/8 suicide and behavioral health crisis fund surcharge. And all of us are now paying right now, if you look on your phone bill, 8 cents per phone line, per access line per month is going to that fund. 30 cents is actually going to the 911 fund. And what it helps us do is, help DHCS, is the Department of Healthcare Services, has been administering funds to staff up the 9/8 centers. It also allows the California Office of Emergency Services to provide the needed technology for the 9/8 centers to use. The bill requires the creation of a couple of advisory boards. One is on technology, resides with Cal OES, and one is on policy, run by us, Cal HHS. So our charge is to come up with a set of recommendations for a 5-year implementation plan for a comprehensive 9/8 crisis system to submit to the state legislature by the end of this year. We're also required to post regular updates, at least yearly, regarding progress on implementation of 9/8 on our public website until the end of the decade. I just want to let you see how we organize our project. It's a pretty complex undertaking for a short amount of time. So you can see right here, we are working toward that 5-year recommendation plan at the top. The Cal OES Technical Advisory Board has been meeting already for a couple of years. We have other state departments that we need to work with and consult with, task forces that we work with. In the middle is the Policy Advisory Group, which has been reviewing all the legislation, taking in recommendations. They had to split into 7 work groups because AB 988 has 14 areas of recommendation topics that the plan must address. And they range from anything that you can think of in terms of looking at national guidance and best practices to addressing regional and statewide population health needs to communications about 988 and behavioral health crisis to coordinating the different systems that must work together to make this work across the state, to having standard ways of doing things. So the 7 work groups have been working over the past year, and then they brought their recommendations and findings to the policy advisory group, which has met for 6 times over the past year, and they will meet for one last time in November to finalize the plan. So this is the key milestones of the project over the course of the year. As you see, we are now in October, and we are going to start our public comment period pretty soon for the draft. Just want to let you know that all the meetings are on our website, which you have the link to in the PDF that I sent to Teresa. So if you wanted to look at previous PowerPoints or recordings for all the work groups and the policy advisory groups, which have all been public meetings, they are certainly all there for you to look at. I do want to highlight the active community engagement that we did over the past year. We certainly could do more and will do more. We just had a very short amount of time to do this, but did want to highlight that the 43 policy advisory group members had met for 6 times. In addition, we have work group members, 140 of them from across the state, representing many different expertise and points of views, and including people of lived experience and peer specialist experts. So they've met for 21 public meetings. We've also held 13 focus groups with communities who have people with lived experience or otherwise have been impacted by the crisis system. So they bring to us specific points of view that can help us with suggestions on how to improve the current crisis system. And there were 90 participants in those focus groups, including 3 focus groups specific to the Native American communities that was led by our Tribal Consulting 988 team. In addition, we've done over 85 individual key informant interviews with a number of experts in the community. Okay. I just want to also highlight the fact that this is not just a plan about the 988 number. In all of our efforts through work groups and speaking with the community, there's a desire that we build a comprehensive system that has, consistent statewide access to everyone, regardless of the source of insurance that they may have and regardless of where they live in the state. And there is a need for high coordination of these crisis services so that we can deliver the best quality service possible to all Californians. So there's a lot that we would want to do with this plan over time. Next, I want to go over what's in the plan so that when it is out there, you get a sense. It is going to be about 100 pages, actually. So there's quite a bit to read through, but I just want to anchor you in really the foundational principles that we are looking at as we spoke about just before, is that we really want to see this as a way for all Californians to have timely access to quality crisis care. 988 should be available and accessible 24/7 via phone, text, and chat, and that the 988 centers really need to have knowledge of how to connect people who are seeking help with local resources so that people in crisis can get timely therapeutic and appropriate care, and that they can be connected to a system that really thinks about community-based support. So the least restrictive response possible, really reducing unnecessary law enforcement involvement, and really a system that really want to prevent future crises and trauma for people seeking help. So the way that we organize our plan is it's really focused on the help seeker's perspective. So let me just go to the bottom of the screen here where we ask 4 fundamental questions. We really want to know, are we building a system where the help seeker will know who to call? We really need to, improve public awareness of 988 behavioral health services, and really engage people in terms of building more trust in the system. The second question is, well, when they do call, will they be connected appropriately? And this is a more complex question than it seems. It's a very complicated system where 988 is going through a national portal. We need to have the technology in the state so that people, no matter where they are at, they will get connected to the right crisis center that knows how to connect them if needed to the local services and supports that they will need. So there's quite a bit to do. Geo-routing has been approved, and that opens up a whole set of opportunities about how to connect people to their community and local resources. And we can talk more about that in a bit. The third question that we really want to know is how good is that number? When you call 988, do you get a high quality service? How do we make sure that the service, which has been really a national service, it is tailored to the needs of Californians, to the populations who speak so many different languages, live in very diverse geographic areas, have multiple different kinds of linguistic and cultural needs. How do we ensure that our 988 system deliver the best quality possible? How do we make sure that happens? And then once the help seeker does get connected and they do need help, will they get access to immediate and ongoing care? What can the state do to make sure that services are well integrated and coordinated? A few other points to the plan. You will see that we really grounded the recommendations in a series of should statements to the state. It would say that the state should do this and the state should do that. And the reason being is that the state has a really new role in 988. 988 has been primarily supported by SAMHSA, and then it now stayed through Mental Health Services Act for so many years. And then now with AB 988, with a sustainable source of funding, it requires the state to now go, okay, how do we make sure that we have good quality services, and how do we make sure that this is not just a number by itself, that it is well integrated into the crisis care continuum and in the context of what we're all trying to do to make a better system in California. Who should take the lead for these implementation activities? Who are our implementation partners to help accomplish these activities at the state, county, and local levels? The timeline for the system, for the plan, is for the course of 5 years. So that's going to start next state fiscal year, July 2025. And we have outlined year 1, year 2, year 3, all the way to the end of the decade. All right. This is a sampling. So our plan, we're still revising it until November 4th when we release it, but I just want to show you what we're trying to think about. So I talked quite a bit about how there are now current national standards. The National Suicide Prevention Lifeline has been around for over 20 years. They have national accreditation. There's a fairly rigorous standard in how the services should be delivered, but that's all been nationally determined and overseen. So where are we in terms of supporting them to meet current national standards? And then next, how do we then build on those national standards and think about the things that we need for the state? We want trauma-informed, person-centered, culturally responsive care. And what are the statewide standards for staffing and training that we need to have to enable our 988 centers to meet the needs of not just suicide-related crises, but all mental health and substance use-related 988 contexts. So here's a number of suggested implementation activities that we need to do. We need to establish the future scope of services that we aspire 98 centers to get to, and identify ways to support them to get there without compromising the current high standards that they actually already currently meet for national standards. What are some things that we have to establish in terms of state level monitoring and support? How do we make sure that we continually assess the capacity of the 98 centers to do their work, as well as meet the quality standards that we are setting for them? Here's another set of activities around integration. Integration is a huge thing to do with the multiple systems at play. So here we have on the left a set of recommendations in terms of what the state should do to promote collaboration and coordination of cross-sector partners, to make sure that individuals seeking help get into care that they need, that we get, connection, coordination, and referrals going, warm handoffs going, and then how do we make sure that there are enough facilities and services so that people can get them when they're in crisis. Some proposed activities, as you see on the right-hand side. We have already, I'm just going to talk about, say, mobile crisis team, right? We've started the implementation of Medi-Cal mobile crisis teams in the state. It's implemented now in 45 counties, covering 97% of Medi-Cal members. We don't know yet how to do mobile crisis team for people without insurance or with other types of insurance, like commercial health insurance. So how do we look at those types of teams, and what are some guidelines that the state can come up with to connect those teams together? All right, so those are just some examples. I'm happy to cover any more in details if you have questions. But let me just go ahead and get to some of the connection pieces. This is kind of like more of our deeper dive into our thinking when we look at what we have in the crisis care continuum versus what we think are the gaps that we have, and then where are some opportunities for the AB 988 implementation plan to address some of those gaps in the crisis system itself, and then how do we link it to the rest of the behavioral health transformation initiatives going on out there. So quite a bit to do, but I just want to walk you back to the crisis care continuum plan, which lays out what we think to be essential crisis services. So really, these are crisis services that we believe should be available to all people in California, regardless of payer source. And many of these services, so the peach colored ones are the ones that we have or will have fairly soon. Do we have enough of them? Likely not, but at least we have some of them. There are things that we're trying to do that are in the blue that has to do with in the next few years, can we get to more of these services that has to do with connecting people to, say, outpatient and community-based care, including responding to them with mobile crisis teams. And then in the gray are more aspirational or long-term type of services that we think we should have way more of. These are more in-home, more welcoming, more peer-based, more person-centered types of care that we definitely need a lot more of, programs and services that people would want to go to. So this kind of lays out the services. This was laid out in the crisis care continuum. But as we do our work in AB 98, we definitely think about, okay, where are the places that we can lean in and provide guidance and support to make sure these things happen. So then one of the things we were required to do by AB 988 is to do a comprehensive assessment of the crisis system and look at where gaps are. And so certainly I don't have to tell you where gaps are in terms of the high rates of suicide in California, certainly by many of our youths and many of our communities who have been marginalized and underserved. So I don't want to need to dwell upon all those statistics that you already know, but really thinking more about what are some opportunities for us with 988 to address some of those gaps. So we know that there's really not much public awareness of 988. In fact, actually, our younger people were more likely to know about 988. We think probably because of the student ID cards that what's printed in terms of the suicide prevention lifeline and now 988. They're also more likely to use text and chat for 988. We also know that, I think I mentioned the lack of statewide standards beyond what's in grant contracts and the need for us to really think about, as a state, how do we adjust to increase volume if more people know about 988 and then other kinds of technology routing, like geo-routing. That's an opportunity for us to go, how do we then connect people to the closest community, most local resources that they have near to them? And then I think one thing I did not mention is that there's a great need to talk about how do we transport people to care, other than going to the emergency department. How do we get them to the behavioral health crisis programs? Okay, and we all know about the lack of beds, so that's a gap in our stabilizing crisis part of the continuum. We all know about the gaps in behavioral health workforce. And not just in terms of the numbers to serve people, but also then the challenges in terms of providing culturally and linguistically responsive care to people. And then we also know about how to the challenges for a crisis care reimbursement. So there's a whole work stream that we've created to look at how commercial health insurance can provide the same kind of behavioral health crisis services that Medi-Cal does provide. Okay. Bear with me. I'm trying out something new here of going, okay, those are the essential crisis services we laid out. Where are some things that we can think about in terms of our cross-cutting initiatives? A lot of our initiatives, including Prop 1, talks about workforce. We've had lots of state bills and assembly bills that talks about parity. How do we enforce those, and how do we support people to get paid? So there's lots of things that we think about in terms of all the different initiatives. But I do want to, so a couple of these slides dive into in more detail, like, we think about the prevention aspects, and we have lots of great warm lines. How do we make sure we connect people to those? So even if they call 988 or even 211, there should not be a wrong number to call, right? We need to be aware of these resources so that if people call a number, they can get connected to the right kind of support. So these are the warm lines, and these are some of the services that we're connecting with. I just want to highlight for you in the plan itself what we are trying to do. So recommendations to the state about how to increase public awareness and trust in the system. We are really needing to create a statewide communication strategies building upon what the federal government has provided. We really need to engage our partners in developing and disseminating communication strategies, both statewide and regionally. So there's a lot of work for us to do, some of which has already been started. But again, there's a coordination role that we have to have so that we do this in concert with everyone. And then, of course, we need to look at how successful and impactful those communication strategies have been so that we can make them better in the future. So we've already seen what hotlines we have. So besides 988, I do want to call out other hotlines that we have in the state, including the county access hotlines and the Health Youth hotlines. And then we've talked about the mobile crisis already. So that's the responding to crisis aspect. So I did want to go back to then, where I had highlighted earlier, what should the state be doing to make sure that the response when people contact 988 is a high quality response. So we are really looking at a state-specific set of standards for staffing and training 988 centers, and we need to develop a process to review, designate, and redesignate 988 centers. What we have is a legacy system. This is what the SAMHSA and Vibrant told us, these are your 988 centers, and they continue to operate, but we haven't had a chance to say, well, how many centers should we have in the state? And who should be those centers? And so those are the questions we're trying to answer. In terms of stabilizing crisis, So again, we try to outline the goal for building more beds, particularly facilities focused on children and youth and crisis services. Prop 1 certainly isn't looking for beds in behavioral health, but also overall housing beds are needed. So again, I don't have to tell you where these gaps are, but I'm trying to go, okay, what are we doing in AB 988 to try to coordinate these kinds of things? So we are told by our advisory group and work groups that the state really should have a coordination role, because our system is so complicated and sometimes quite fragmented. So we really need to have a larger role in connecting, coordinating, and making sure people get referred to the right care when they need it. And then building facilities and then making sure people can get to those facilities. So I think that's kind of boiling it down to the basics here. And then some cross-cutting issues. I apologize for this very busy slide, which again, I'm just trying to get a connection of where are all the pieces that we started, right? CHIP started a few years ago, and Prop 1 is going to be implemented next year, or not next year, but in 2026. So there's like a lot of pieces of the puzzle that we're trying to pull together to make sure that we're driving toward the same goal, so that we can work in concert and synchronously with each other and synergize all the efforts rather than duplicating all the different efforts that are going on. So in that vein, what are the recommendations in terms of some of these cross-cutting issues that we are taking into account and implement in the 5-year plan? We really need to prioritize inclusion and equity in our crisis care service delivery, knowing that we have lots of gaps in the system. There are many populations that are at higher risk for crisis, as well as experiencing historical discrimination and prejudice. And really, we need to adapt and tailor services so that there's equitable access for people who have those kinds of barriers to access. We also should really think about, again, behavioral health parity. There are some really major barriers to people accessing care because of cost and whether they have insurance payment or not. We also need to build a more centralized data system that can tell the story, that both helps us monitor the quality of the services, but also a public-facing dashboard, if you will, to then tell the story of how we are doing. Is what we're doing really making a difference? Are we building a better system and helping people's lives better? So that's something that is on our list of things to do. And we've had lots of really great recommendations and suggestions from our peer support specialists and family representatives to how to integrate the peer support to support a care system that is more recovery oriented. Okay. I'm gonna get to the next, so upcoming events for this plan. We will post the plan on November 4th on our website. The website is linked here. We will hold a public informational webinar on that day from 12:30 to 2 p.m. You can register by clicking the link here. We will have a public comment period from November 4th to the 14th. This is to time it so that the final policy advisory group can get together in Sacramento on November 20th to work through the plan. It is a public meeting. People can either join us in person at the Allenby building or virtually, and all the information is available on our website 10 days prior. We will post the plan that will get reviewed around November 13th. Okay, and these are some resources for you to look at further. And definitely please email us with any questions or feedback.
I was just wondering if
Oh,
you
hold on.
could. Thank you so much, Dr. Bui. Really appreciate the presentation and all of the information that you shared. And it is on our website, and we'll put the recording on the website too, because I know many of you may want to provide this to your local boards to look at. So yeah, let's go ahead and we'll start with some questions. And I think Amber from San Francisco.
Yes, I was wondering if you're gonna connect a language line to them so that everyone can be able to talk when they call into this 988.
Yes, absolutely. The way that it is currently configured, when people call 988, they can request a translator for their preferred language, and they are connected to, I believe, right now 240 languages.
Great.
Yeah, there is also a Spanish subnetwork, by the way. So when you call 988, you have a choice of pressing 2, and that will connect you to a Spanish-speaking crisis counselor. And I can send you the links. You can, and that there's also chat and text available in language for Spanish. But yes, there is translation for the other languages.
All right, and I think we have some questions in the room. Just a moment.
Yes, I wanted to do a mic check real quick. Can you hear us online?
Yes.
Yes, you could. Okay, thank you.
Yes, we can hear you.
Good afternoon. My name is J.D. Eaton. I'm on Cal BHBC, and I'm with Solano County Chair for the Solano County Behavioral Advisory Board. So my question is, you mentioned 12 centers for the 988 calls. Where are these 12 centers located, in what cities?
Yeah, I have a list of them and what city. I don't have it off the top of my head. They are actually one feedback that we certainly have heard is that they are primarily located in large cities, right? So Los Angeles, Sacramento, Oakland, San Francisco, San Diego. And if I gave you a map of it, it does look like the 12 centers physical location are actually in the major cities, therefore leaving a fair large gap of northern, rural, frontier, desert communities not having a 988 center physically located in their community. But I can send you a list that has all the cities listed.
Thank you.
Do we have anybody else in the room? Okay. Yeah,
Hi.
introduce yourself and county.
Yes, I will. Hi, my name is Steve McNally. I'm from Orange County, and I'm on a local behavioral health board. I have a son with schizophrenia, and all my comments are as an individual. Thanks for your presentation. I had a couple of thoughts. One is when you said mobile response is implemented, I was going to ask what your definition of implementation is, because the money is out the door, but it's not actually working yet as fully implemented, at least in our county. I mean, there's still a ways away from getting it fully up and running, and it will be terrific when it is. But so how are you going to monitor that? Two, your focus is to be on the health seeker, but I was looking at the list of membership on this advisory committee, and I just see providers. I don't see health seekers as far as community members. So it might be a big lift to present it to the community, make sure they understand. And lastly, the 988 with the area codes, have they fixed it with the cell phones yet? Or is it still, because that was a big issue, and that might be outside of your purview. But thank you very much. There's so much great stuff going on. It's sometimes hard to keep up with.
Yeah, absolutely. Thank you for all your great questions. These are fantastic. And let me just try to make sure I am keeping up with them. Thank you for sharing. Mobile crisis, yes, absolutely. When we say implementation, we mean that the Medi-Cal mobile crisis services, that the counties have submitted the implementation plan, right? But really, the Medicare mobile crisis benefit only started in January of 2024. So we are now here in October, right? How does something get implemented to the extent that we want it to be? So Medicare mobile crisis is being done by the Department of Healthcare Services, right? They oversee Medi-Cal in our state. And so they monitor these implementation and work with the counties to make sure that they get the services there. We have had mobile crisis, right, for decades in our communities, but that's been funded by a variety of different kinds of funding, primarily Mental Health Services Act and county funding, and a variety of braided funding streams. So right now, it's an opportunity for Medi-Cal to pay for this benefit. So yeah, there's a lot of things that we gotta do and build. And it is really, as you mentioned it, at the beginning. I'm sorry, I am gonna need some help to make sure I address the other parts of your question. I can send you a list of PHE members for who identify themselves as having lived experience. So we can do that. We do have people who with lived experience and self-identify as help seekers or peers or family members in our work group and policy advisory board. Oh, your last question, the cell phone, do you mean geo-routing, area code versus geo-routing for 988? Was that the
Yes,
question?
yes.
Yeah, so right now we are still in a mixture environment. So as you all know, 988 has been routed by the national portal, by the area code. Really, the first 6 numbers of your phone is how you get routed. But as you know, people move around. So I have a 619 area code phone, but I live in the Bay Area now. If I call 988 through my cell phone, because my carrier is AT&T, I would get connected to the San Diego 988 centers, which is run by Optum. However, recently on September 17th, 2 of the major carriers in the states voluntarily switched to geo routing. So that's that's Verizon and T-Mobile. That covers about 50% of people who call 988. So then some of us who use T-Mobile and Verizon would get connected to the closest 988 center to us physically, and it's done through kind of a approximate location via cell phone towers location. So it's not exact geolocation like 911 to preserve privacy, confidentiality. Just yesterday, I believe the FCC announced that all carriers must go to geo-routing. So I believe within 30 days, the other major carriers would have to go. So that would include AT&T. So we're kind of in a time of change where we're still having a mixture of area code routing and routing by geolocation.
Okay, thank you. Jeffrey, would you like to go ahead? Is there more in the room?
Yeah, thank you, Teresa. And thank you so much for this informative, excellently presented presentation. I had, it looks like I have 5 things I wanted to touch on. We're working, I'm the secretary for Santa Cruz County Behavioral Health Board. We're working with RI to lift up the mobile crisis response. And their comment right from the start was that California is burdened with regulations that really slow things down. So I just wanted to make that comment that are we looking closely at the Arizona model and how they've been able to have their success points. Another point is in the beginning of your presentation, and correct me if I'm wrong, you mentioned the surcharge for 988 is 8 cents and the surcharge for 911 is 30 cents. And so my point is about equity and how to get equity. So I was looking at that, how do we increase that surcharge? The other is looking at EMS response times in our area. For Santa Cruz, if I fall down and break my ankle, EMS has a 20-minute response window. Our mandate for our mobile crisis team, if I'm in a crisis, in an urban area is 1 hour. In a rural area, it's 2 hours. So how do we get more equity there? And then jails rather than beds. So right now we've got in Santa Cruz, they want to put 200 more jail room beds in, and we have 16 beds at our PUF, and there's no support for increasing that. My last point is that I wanted to make people aware of the HR 8575, which is a bill by Daniel Goldman out of New York to increase the IMD bed reimbursable limit from 16 to 36. And we're reaching out to the boards trying to get more people, more representatives to co-sponsor that bill. Again, Anne, thank you so much. This gives us a lot to go on. And Teresa and the rest of the board and everyone there, thank you for your service. Everyone be well. Thank you.
Thank you. And we have another question in the room, so we'll switch over. Oh, yeah, let me let you answer and then we'll move on. Sorry.
Okay, yes, thank you so much for your concern and bringing up, again, really important issues. I actually love hearing about what's happening and what you're grappling with at the local level. And if you have certainly solutions or innovations that you want to uplift, we can always learn from those, right? So that's good to know. Yes, we are looking at different states for different models that we can learn from. We actually meet pretty regularly, all the states together, at least a couple times a month. There's only been 10 states that have passed the 98 surcharge legislation, so we are in a bit of a new world here, trying to figure some things out together. But absolutely, there are lots of great models to learn from other states, and that kind of cross-learning is absolutely crucial. I do want to let you know that the surcharge for 98 can be increased starting calendar year 2025, up to a limit of 30 cents. So yes, it just started at 8 cents and was capped at 8 cents for the first 2 calendar years. But starting calendar year 2025, it's possible to increase it. It would have to be done through the state legislature, through their budget process. Just in terms of increasing IMD beds and the ability to pay for Medicaid and Medicare to pay for behavioral health services in facilities with more than 16 beds. That is the BH Connect initiative that you see that will get implemented in California in 2026. So the idea is to not have a lockout in terms of what can be paid for by the federal government and the state, and therefore having to be shouldered by counties and local resources. So that's an exciting initiative that is still, I believe, we're still waiting for some more negotiation with the federal government, but we are hoping that it's going to move toward, again, more options for our communities.
Okay, thank you. All right, so we have a couple more questions. Introduce yourself.
Hi, Barbara Wilson from Los Angeles County, and thank you so much for this presentation. I wonder if you could, and maybe you've already addressed this issue, but we have had some people that are very concerned about their privacy. Apparently, there are a number of online therapeutic kinds of organizations, including 988. And so what can you tell us that we could go back home and tell others that their privacy is absolutely protected on 988?
Okay, great. Yeah, no, that's a very important question. So 988 is a free and confidential service. You do not have to identify yourself. Um, um, in fact, many people do not. I think on any given month, we don't have data on who is calling. Obviously, you can be identified by the phone number that you call in. And so there is a way that 988 centers do keep track of people who use 988 on a regular basis. And those people actually do have a choice of providing, say, a pseudonym. So if they don't want to have to tell their story over and over again, and they do use 988 on a regular basis, there are people who do use a pseudonym so that their background, if you will, can be pulled up when they do call 988. So that's one aspect that I thought was a nice person-centered way to provide that service. But yeah, by and large, you are not required to provide any information when you call 988 about yourself that you're not comfortable revealing.
Thank you. And we have
Now, I do have an exception to that, and this is something that community members have brought up as concerns. Because it is a national suicide prevention lifeline, they do assess for suicide risk at the beginning of the call and at the end of the call. So people who are thought to be at imminent risk for self-harm, suicide, and there's also additional concern about public safety if, say, there were, so there are so many, I'm sure there are thousands of scenarios that we can think of in which we don't regulate, but they are trained and nationally accredited to assess for imminent risk. And there's like whole things that I can send you around all that safety assessment risk. There's a very small amount of 988 calls that do get transferred to 911 for when there is imminent risk for emergency rescues or public safety issues. And that's where we have the highest concern about the confidentiality and privacy. And that's, I will fully acknowledge that is a tough place to try to figure out, but we will continue to talk about those together and figure out how to work on that together.
Thank you. All right, another question in the room, and then we have one online. Go ahead.
My name is Gregory Farron. I'm from Sonoma County. I'm a newcomer to the Behavioral Health Board, and this is actually my first meeting at this group. My question is, to what degree are you helping the other 40 whatever counties implement this system? And I'll give you an example. In my county, Sonoma County, you didn't mention it, but we're sort of a middle range, and we've got 3 cities that have in response, like the rapid response teams that started out the process of helping us. And then the county, because we have a sales tax that raises $34 million a year, dipped into it to be able to set $11 million aside to set up 10 roving 24/7 micro vans with staff. So we're sort of jumping feet first into the process, but and we have a dispatch center that's separate. So we're kind of almost up fully, but we don't know whether we're doing it right. We don't know what staffing levels we should be having compared to anybody else. We really don't have a way to be able to easily compare ourselves and or learn from others. So my recommendation is that and we all don't like too many stakeholder groups, but I would recommend some way in which all of us can get together and share what we're doing, how we're doing it, how we're funding it, and whether or not it's realistically, possible to transfer this into Medi-Cal. I don't want 11 million of my 34 million Measure O tax money to constantly pay for what now is basically a large, very expensive taxi service to the ERs.
That is a great innovation. And again, I think, as I mentioned earlier, yeah, it's hard to know all the different efforts out there. So that's so cool that your cities got together and pulled together these response teams. I think that's great. How do we get more information to know whether we're doing it right? SAMHSA is releasing a set of toolkit for mobile crisis services at the end of the year. We are eagerly awaiting any toolkits because, to be honest, at the state level, we're always trying to understand, right, best practices and standards. So absolutely, I think gathering standards together is fantastic. Whether it can go to Medi-Cal, for Medi-Cal, there's a specific set of standards, and I can certainly send you what those are through their behavioral health information notice about Medi-Cal mobile crisis. But it's very specific in terms of team composition, 24/7 availability, things like that. So for Medi-Cal, that's all spelled out. But yes, when you mention innovative city or local jurisdiction teams, there's a lot going on. That's very exciting to hear about.
Thank you. Michael Lim?
Hi, thank you, and for the wonderful presentation. And I am so happy that we are finally making geolocation work, or finally putting that in place, because the peer community has been advocating this for a long time, because we were having a lot of issues, connecting to resources, right? So my question now that we have that in place is to drill down further and make this better. Is that when they dial 988, it goes to a central switchboard, and then the technology of geolocation kick in, and then that's being routed to the particular county, right? So my question is, are we keeping track of, or are we, what would you say, gathering metrics in terms of what is the response time from when the call is initiated to when the call is being picked up by a human? The reason I'm asking is, excuse me, there has been I wouldn't say a recent article, but it's been quite a few months now, where NPR did an article on the response time. Firstly, the history of crisis calls and the response time between the initiated call to for the call to be picked up by a human, because through that time, if the long is wait, that person just drops off the call. Or if the messaging on that of the whole message is inappropriate, they fall off that also. And since we're dealing with the situation where the caller has 1 foot in, my pain is so great, I don't want to go on living, to and a foot in the other side where, but I don't want to die either. What do I do? So that's a very precarious moment there. And I was hoping you could shed some light on if we are collecting metrics and how to improve that process.
Yeah, thank you for your question. If I may just say that we are at a geo-routing situation for 988, not geolocation, with the way that 911 system works, which is geolocation is identifying where the person is at, whereas geo-routing is just an approximate area to then route the person to within the county where they are physically located.
Yeah, sorry, I misspoke. You're absolutely right.
Yeah, so this is still very complicated and only just began to be implemented on September 17 for half of the people using the service. So metrics, yes, are being gathered, not by us. Metrics are being gathered by the National Administrator of 988, that is Vibrant Emotional Health. They do provide information about time to answer, average speed to answer, I believe it's called. They have a whole complex routing thing where I think it's like you get routed to the closest 988 center, but if it's not picked up within 120 seconds, I believe, it gets routed to a backup center. So that's still a very long time, by the way, right? So those are some serious questions that we have about how do we get people connected as soon as possible. And it really has to do with availability of counselors. And there's a whole lot of stuff that we got to do technology-wise, so like predicting when is the highest volume call to make sure that you're staffed appropriately so that you can answer all the calls as fast as possible. So all those things we are working on. We don't have a way in California to monitor those ourselves, but with the system that the California Office of Emergency Services is building, that will be more in our control in terms of centralizing the data collection, and then therefore being able to. There's already quality improvement efforts going on right now, but that's more again through federal efforts than what it is we're doing in the state. So part of what we're trying to do is, what do we need to do in the state to monitor, incentivize, support the quality of response, including the speed of response.
Yeah. My question and comment is more of, it's great that we're moving in the right direction. It's just that, we have to fine tune it and keep an eye on it. And I hope, Cal HHS would continue to monitor that and keep an eye on that, because it involves a lot of technology. I used to be in the telecommunications industry, so I understand the federal authorities having their it goes into a central federal number and then being routed to the state and things like that. So I understand the complexities of that, but I hope that California will continue to keep an eye on that and fine tune that process for our community.
Absolutely.
Thank you. Let's go to JD here in the room.
How you doing? This is JD Hatchett again. So my question is, are they trained in behavioral health? And we do know that substance use disorder and mental health crisis is two separate things, but yet we're implementing them both together with this new thing now. So are these people at 988 trained to, you're not seeing somebody face to face, so you're on the phone with them. So is the person trained on the phone to recognize if the person is in crisis, or are they coming down off of a high? So that way they can be rerouted to the right destination they need to go to.
Those are excellent questions. The 988 Center crisis counselors undergo a set of training that is required by the national administrator. Usually that involves somewhere around 40 to 80 hours of training, but it's also going to vary according to the center itself. We do not yet have a statewide set of baseline standards for training. And I think that's what I was trying to highlight before. We're trying to build upon, yes, they are trained to do what's called de-escalation of crisis, but do they really know all the nuances of all behavioral health crises, including substance use challenges? That would be a new category of responsibilities for which we would need to support them to get there. Mainly because, again, remember, they've been the National Suicide Prevention Lifeline for over 20 years. Many of the counselors are licensed clinicians, but many of them are also volunteers with lived experience, usually with lived experience with suicide, they being suicide survivors themselves, or having family members of suicide survivors. So I would have to say, admittedly, their strength and expertise is really on suicide prevention, right, which can encompass many different behavioral health conditions. But to get to that other level that we're thinking of will require us to set state standards for what we want them to do and state standards for training and supporting them to do those things.
I'm still not clear. Like I said, you're talking about the train. I'm still not clear on if a person's in crisis, but they're coming down off of a high, how we're trying to reroute them to the right destination to get the services and help they need. So if nobody's trained, or if they are trained with lived experience, so that's what I'm seeing a gap at. That's what I'm having a hard time seeing, because if I'm on the phone with you and I'm talking to you and you can't see me, so you don't know if I'm in a crisis or if I'm just coming down off of a high. So I don't necessarily, I'm not committing suicide. I'm not thinking about suicide. But at the same time, you don't know if a person's in crisis or if they're coming down off of a substance use disorder to get them in the right place. And I think that's a gap that needs to be identified.
Yeah, and I think your question about getting them to the right place for care, for example, if they need a substance use program, for example, yes, the counselors have resources that they can refer people to and connect people to, including also a warm handoff if they have those kinds of local relationships in place to connect people to that. They are trained in a number of different crisis scenarios, and you know, they vary in terms of their expertise. They also have supervisors available to help them. So they have lots of support and trained to deal with lots of different kinds of crises. They have pretty good results, but I would have to say there's a lot of work to do to make sure that they can do everything that we want them to do.